Hi, my name is Dr. Diego Marin. I am a pulmonary and critical care fellow. The point of this video will be to just kind of give you a quick brush up slash refresher on mechanical ventilation. I do have legal disclaimer real quick. This is not meant to be for the treatment of patients. This is for educational purpose only. Anything you do with the information in this video is entirely up to you. I am not legally responsible. Now that that's out of the way, this is mostly meant for fellows of other specialties, hospitalists that may have graduated 1, 2, 6, 10 years ago, and just kind of want a quick refresher on mechanical ventilation as a whole and how to take care of patients. This is going to be very, very abridged, done as quickly as I can possibly think of doing it with all of the pertinent pearls that you may need to do this job quickly and efficiently. First things first, why do we even intubate people? I want you to think of it in a broad umbrella of safety. You are trying to protect your patient, whether it be hypercapnia, like in a COPD, or hypoxemia, like it is in these COVID patients, whether it's airway protection in someone who has a huge laryngeal mass or someone who has a stroke. All of these are for patient safety. Remember, a ventilator is like a chainsaw. It is a very useful tool, but it is also potentially very dangerous in the wrong hands. So the point of this is to make sure that you can use your chainsaws efficiently and not cause any harm. Although ABGs could be their own video, we're going to just quickly review normal ranges. Remember that there's no specific number. It is all ranges. pH, anything from 7.35 to 7.45 is normal. Anything above 7.45 is considered abnormal. That would be considered alkalotic. Anything below 7.35 is considered acidotic, also abnormal. PCO2, 35 to 45 is your range. Anything above 45 is hypercapnic. Anything below 35 is hypocapnic. And PO2, ideally you'd want something above 55. 55 is really where you should start to get concerned. 55 will equal anywhere between 88, 89% oxygen saturation on your pulse ox. It is not obviously ideal, but maintaining balance between oxygen toxicity with high FiO2 levels and trying to keep these patients in a happy place, 55 should be your absolute minimum. So for the purpose of this video, we're going to basically stick to two main modes, which I think will be sufficient to get you to be able to take care for these mechanically ventilated patients. One of them is PRVC, better known as pressure regulated volume control, and we will also go a little bit into pressure control. With these two modes, you should be able to take care of a majority of patients. Understand that PRVC is actually a type of pressure control mode. Even though it ends in VC, like if it's volume control, it's actually not. It's pressure regulated. The only difference between PRVC and PC, pressure control, and pressure regulated volume control, is that pressure control is a set pressure, and whatever result you get is actually a tidal volume. Whatever tidal volume it gets is the tidal volume it gets. Unless you set certain alarms, the mode will not care. The ventilator will not care if you're not getting a tidal volume that you don't like. If you're getting a tidal volume of 200, which by the way is not enough on most people unless they're tiny or we're talking about peds, but this is for adults only, the tidal volumes will just be what the tidal volumes are. There has to be alarm set in pressure control for you to realize that there's something wrong, or you have to be very vigilant, looking at the vent, looking at the tidal volumes you're getting with each breath. If there is a change in either compliance or resistance, your tidal volumes will be lower versus being higher. That being said, pressure regulated volume control is beneficial in that it will up titrate and down titrate the pressure on top of the PEEP, also known as the driving pressure, to give you the tidal volume that you request. If you set the tidal volume to 400, it will each breath try to give enough pressure to get just around the tidal volume that you request. If the compliance decreases, i.e. you have stiffer lungs, or if the resistance increases, making it harder for air to flow in through the ET tube, the airways, whatever it may be, your tidal volumes will go down, so your PRVC mode will up titrate the pressure. That is both beneficial and potentially harmful because you have to have the right alarms. Without the right alarms, the pressure will just keep going up and up and up and up in an attempt to try to give you the volume that you requested. So the only other thing that you will get in an ABG that I didn't mention is bicarbonate. Now, the reason I didn't mention it is because in an ABG, this is actually a calculated value, not an actual measured value. What do I mean by that? If you guys remember the Henderson-Hasselbalch equation, it has to do with the pH, the carbon dioxide, and the bicarb being in a constant balance in between. Now, in the case of an ABG, it will measure your pH and it will measure your PCO2. The problem is that it just backward derives your bicarb. The bicarb in a BMP or a CMP, Chem6, whatever you want to call it, is an actual measured number. So just something to take into consideration, that the value that you get in an ABG for bicarbonate, which by the way, bicarbonate should be between 22 and 26. That is your usual range. If it is out of range in your ABG, but in normal range in your BMP, CMP, just remember you have to take the one in the ABG with a grain of salt. So how do we use a mode like PRVC in order to obtain values that we like or we want to keep normal? Well, when it comes to carbon dioxide, I've written it out, and it is basically a function of your respiratory rate, which you set, or the patient breathes above, remember you're setting a minimum, multiplied by the tidal volume that you're actually set to. This will give you a minute ventilation, for example, like we gave before. Or let's make a new example. Let's say you're breathing 20 times a minute and you're using a tidal volume of 400. That is approximately 8 liters. If your PCO2 is out of range, let's say it is above 45, which we said is the upper end of normal, you would want to change either the respiratory rate or the tidal volume in order to increase your minute ventilation so that you can decrease your PCO2. If you have a PCO2 that is low, below 35, and you would like to increase it because now the patient may be getting alkalotic, their pH may be above 7.45, then you would want to decrease your minute ventilation. You can either decrease the respiratory rate, which is pretty easy to do, or you can decrease the tidal volume, which you pick, we will go over very shortly. As far as oxygenation, you will also have seen it here in the bottom. Oxygenation will be a factor between the two other settings that you will likely have control over in most ventilator types. That is the fractional of inspired oxygen, which is how much of the air that they're actually getting is oxygen. Normal oxygen is 21% in the room air. In a plane, it's 15%. In Mount Kilimanjaro, I'm not sure. But basically, it's lower. The higher you go up, the lower, but at room air, in most situations, it is 21%. You can titrate this as much as you'd want. You can put a patient on 100% FiO2. And you can also manipulate the PEEP. Now, something to understand about both of these things. Right now, we are going, at least to as late as this video is, we're treating COVID-19 as similar to ARDS. Whether it actually is something that is being contended, and it is not clear. We don't really understand exactly everything about COVID. It is still too early to tell, but we are treating it similar to ARDS, and some people are recommended higher PEEPs. There is a problem with higher oxygen, which is oxygen toxicity. One quick tidbit that I can give you is that if you want to get an idea of where a patient should be with a set FiO2, you can multiply their percent FiO2 by 5. What do I mean? If you give somebody 40% FiO2, multiply by 5 would be 200. You would expect on their ABG to get a PO2 of at least 200. If it is less, then obviously the patient has a low PF ratio and the patient has an AA gradient. If you remember all of those things, which again, those could be separate videos if you guys would like. The best thing that I can advise for you is that if at least the way that we are treating COVID-19 now, you can look up ARDS tables from ARDSnet where you can titrate PEEP and FiO2 together in obese and not obese patients. Those are very easy things to look up real quick. That'll give you a basic idea, if we are continue to treat this similar to ARDS, how to titrate both of them. Understand, like I said, higher oxygen levels do come with a risk of oxygen toxicity. And you also have a risk with PEEP. PEEP is something that a lot of people do not feel comfortable with. Doing pulmonary, you have to be comfortable with high PEEPs. We have people in the COVID unit on 20, 22, 24, 26 of PEEP. What is the main issue with PEEP? Well, it is end expiratory pressure. The reason PEEP helps with oxygen is if you think about the way that oxygen goes up and down in a ventilated patient. You have the basal level, which is your PEEP, right? 0 is here, but you're holding a certain pressure above. Then you hold a pressure for a certain amount of time and then you let go. And then you hold a certain amount of pressure and you give more and you let go. This basal, everything under the curve results in oxygenation. So if you go from 5 of PEEP to 10 of PEEP, the whole bottom part is a function of how much oxygenation the patient's going to get. This is why we use higher PEEPs, and why higher PEEPs result in more oxygen. You're pressurizing the system. It's not just a recruitment tool. You're recruiting more alveoli, which is what everyone kind of remembers when they think about this. It's also just a function of pressure and oxygen at the same time. So PEEP does have its issues, in particular venous return. You're pressurizing the chest. And when you pressurize the chest, you risk having issues with venous return, IVC and SVC. Remember, those are low pressure systems. If you pressurize your chest to 20, that means the venous pressure has to be at least 20 just to get into the thoracic space. So you can have an issues with preload. This can be a problem if your patient starts to get hypotensive and you start having to balance out things like PEEP and vasopressors. So sometimes you may want to kind of come back on the PEEP if you're having an issue with pressure, understanding that you may sacrifice PO2 in the process. So that's basically in a nutshell how to utilize both tidal volume, respiratory rate for PCO2 management, and PEEP and FiO2 for oxygenation. Your goal should be to get your patient off of 100% FiO2 as quickly as possible. Now, when the patient is freshly intubated and you first get the patient, you kind of have to let them hang out at 100% FiO2 for a little bit. Now, a little bit means maybe 30 minutes to an hour. After that, or maybe even immediately after, if you're at the bedside and if you feel comfortable, you can start to up-titrate the PEEP and the FiO2 with a goal of trying to bring the FiO2 down to a little bit better level. What's a better level? Honestly, anything less than 100%. If you can get it down to 80, if you can get it down to 70, all of those things would be fantastic. You can up-titrate the PEEP. Most respiratory therapists will usually start at 5. You can titrate up to 8, 10, 15 in some of these patients, at least, again, with the given recommendations, which change every single hour, almost feels like, and try to get them to a place where at least you can use an oxygen saturation. If you have a good waveform, a pulse ox of above 92%, you should be okay with. That being said, it shouldn't be your goal to get them down to 92% either, but if they're setting 100%, they're getting plenty of oxygen. You don't have to be so concerned and keep them at 100% FiO2. You can down titrate that until it's tolerated. Now, this does mean you have to sit at the bedside for at least a few minutes as you play with these things to make sure that there isn't a wild swing. You don't want to go from 100 to 70 like in one shot and just leave the room. But it is something to be aware of, something that you can try to aim for and not just leave these patients at 100% FiO2 for like hours on end. Keep in mind that the PCO2 may be normal, i.e. 35 to 45, in someone who has a pH that is less than normal, less than 7.35. This is likely metabolic acidosis, in particular if the patient is going into renal failure, and their bicarb on the BNP is dropping every single day as the creatinine and BUN go up every single day. So the patient may not have a respiratory issue. Now, if you want to try to compensate for a metabolic issue temporarily, you could do that. You could increase the amount of ventilation to try to bring the pH back to a little bit more normal level. Let's say you have a pH 7.22 and your bicarb is 16, 15, somewhere around that range, and your PCO2 is 36. You could hyperventilate the patient to try to bring their pH to a more alkalotic side of things, since you're on the acidotic side, i.e. you're going to bring them towards normal. Ideally, you want to fix the underlying disease process, always, so do keep mindful of that this would be just a temporary fix. To end this video, I thought that we could just quickly summarize at least how to pick a ventilator settings in the first place. In most scenarios, you will probably want to stick to PRVC. It is widely known, widely accepted. Most people feel comfortable with it. You are going to be able to kind of get a ideal mechanical ventilation scenario where you will have a control of pressure, but also an ideal minute ventilation with it. For ideal body weight, which is what you should use to choose a tidal volume in such a setting, in both males and females, 5 feet is the standard. This is just the equation if you'd like to know. For males, it is 50 kilograms at 5 feet. For females, it is 45.5 kilograms at 5 feet. And for every inch over 5 feet, you get an extra 2.3 kilograms. That means that for a 5'10" male, you're looking at about 73 kilograms. If you're using protective lung strategy with low tidal volumes, and you want to use 6 milliliters per kilogram of ideal body weight. Remember, just because you get fatter or you get skinnier doesn't mean your lungs get bigger or smaller. So that's 5'10" male would need approximately 438. You could round up to 450 or go down to 420. 10 milliliters is not going to make usually so much of a difference of tidal volume. So 420, somewhere between 420 and 450, 440, you should be okay for their tidal volumes. A respiratory rate usually will vary a lot, and you're going to get an ABG usually shortly after intubation. So you can choose something like 14 to 16 and go and see where the ABG is kind of leading you. Obviously, if the patient had a recent cardiac arrest, they're going to be acidotic. You're going to want to set the respiratory rate a little bit higher to kind of help with that acidosis that you know is going to be present from someone having a cardiac arrest. And when it comes to FiO2, the patient is freshly intubated, like I mentioned before, you're going to start at 100%. You can work your way down later. Similar with PEEP. The PEEP, you're usually going to start with 5, which is kind of seems to be the minimum for reasons outside of the scope of this video. And you can titrate the FiO2 down and the PEEP up and try to find a happy balance without sacrificing things like oxygen toxicity or having to drop somebody's mean arterial pressure because you're going up so high on the PEEP. Now, when it comes to pressure control, you should still have an idea what kind of tidal volumes you'd want. So let's say you know the same 5'10" male, or we can use the example of a female. So again, let's say it's a 5'6" female. That's 6 inches multiplied by 2.3 is 12, like 13.8. 13.8 plus 45.5 is almost 60 kilograms. So a 5'6" female would be about 60 kilograms ideal body weight. You multiply that by 6, you're getting about 360. So you're going to want a tidal volume of approximately 360. If you set them on pressure control, let's say you start with 15 over 5, right? So your peak pressure will be 20. Let's say that gives you a tidal volume of 300. And you kind of look, and every single breath, you see only 300, 310. Okay, you can go up a little bit. Now you can you may go to 20 over 5 and you'll get tidal volumes of 400 and something, and you'll have to step it back. You can titrate that driving pressure to try to get the tidal volumes that you are looking for. And again, we're using preferably 6 mLs per kg. And the kg is the actual ideal body weight, not the measured or any other thing that you may have heard. That's the equation for ideal body weight that we use for mechanical ventilation for ideal body weight. And to quickly kind of go over as your patient gets better, let's say you start coming down on the FiO2, you start coming down on the PEEP. If you are usually around 40% and 10 of PEEP or less, your patient is likely doing pretty well from an oxygenation standpoint, possibly well enough to be extubated to something like BiPAP. Now, they're going into extubation is a whole nother topic, but to keep it quick and simple with the help of your respiratory therapist or people maybe potentially pulmonary critical care at your facility, you can go a little bit more into this. But you can do a pressure support trial. What is pressure support? Pressure support is kind of like pressure control, except you don't control it, you are only supporting. The patient has to initiate all breaths. There is no background necessary rate. You will set a pressure like you will on BiPAP, very similar, of a pressure on top of PEEP. Let's say you put 10 on top of 5. Now, the patient may get a tidal volume of 600. Whoa, big tidal volumes. That's good. That's a good sign because that is partially the effort of the patient. That means the patient is probably doing better. The patient does need to be, one, at least semi-awake, minimally sedated for you to do these things, and cannot be paralyzed. Okay, paralyzed patients can't start a breath. If you put somebody that's paralyzed in pressure support, they will not breathe. They need a background rate because they don't start breaths because they're paralyzed. You remember this. So, let's say you put somebody on 10 over 5 and they're doing fantastic. One of the things that you're going to be looking for is called the Rapid Shallow Breathing Index. Now, what is that? If you have a critical care event, most of them have it that they will show it to you. You can ask your respiratory therapist to show it to you. Most respiratory therapists will also do like spontaneous breathing trials on a daily basis, unless the patient's like on max vent settings, to try to see where the patient is at. If you see anything less than like 105, that's good. The shallow breathing index is the respiratory rate divided by the tidal volume in liters. What do I mean? Let's say you have a patient breathing at 20 all on their own with just a little bit of help. They initiate all their own breaths. They're not tachypnic, right? Because tachypnea is bad. It means they're not ready. They're breathing too hard. Let's say, in most cases, let's say you have tidal volumes of 500. So you're dividing 20 by 0.5. That is about 40. That's good. That's pretty good. That means they're nice and calm. They're breathing at 20. They're bringing big volumes. What you don't want is someone who's having quick, shallow breaths, because that patient is not going to tolerate being extubated. They are not ready yet. So anyone greater than, you start getting 140, 150 on the SBI, they're not ready. You get someone who's breathing 40s, and they're breathing 200 milliliters every breath. That is what, 200? They're not ready. They're breathing way too quick. They're not ready. So you need a patient, ideally, a patient who is awake, can follow commands, can listen to you. You can tell them breathe deep and slow, and you will see it on the ventilator that they are actually, in fact, following commands. They can give you a thumbs up. They can take a deep breath when requested, when instructed, and they can keep their breathing rate nice and slow and take good deep breaths. Those patients are usually ready to be extubated. One other quick test that you can do is ask the patient to pick their head up from the pillow. It sounds very simple. There's actually data on it, and it's a pretty good indicator that the patient, one, can follow commands, two, one, can listen and follow commands, so they have executive function, and two, that they still have a decent amount of strength to be able to pick up their head from the pillow with the ET tube still in place, okay? And they can just lay it back down. They can pick it up on command and lay it back down. Those patients are usually ready to be extubated. So those are the people that you can either try extubating to BiPAP if necessary, and depending how they go from there, you can kind of step them back into like a non-rebreather, maybe even a nasal cannula. People that are on the higher PEEPs, like 10, if they're like fine and awake and their SBI is perfect, those patients are usually going to need a little bit of BiPAP, just because their PEEPs are a little bit on the higher end. But if you have someone tolerating 40%, saturating 100%, and PEEP of 5, and they're wide awake and they lift up their head, those patients, you could probably just extubate them to a non-rebreather. Again, this is something that you'll pick up with experience, and every patient behaves differently, so you will need to be ready to be surprised. You may expect one thing, and your patient may need to be reintubated. Also remember, you don't need an absolutely perfect patient for extubation. If you look at the literature, if you don't reintubate 1 out of every 6 patients that you're extubating, you're probably waiting too long to extubate. Now, that just means you're too cautious. So you may be keeping patients unnecessarily too long on a ventilator because of apprehension. Now, that is understandable, but in a controlled hospital environment, patients can be ventilated non-invasively until either anesthesia or someone else can show up and reintubate the patient. So under most scenarios, it almost behooves you to be a little bit more aggressive rather than apprehensive. Particularly in a pandemic like this, where we're very short on supplies and we need everything that we have. So that's everything for me. I hope that this video was educational. I hope that it was a good review. I tried to be as quick as I could. There's definitely a lot of information. There is way more information in terms of mechanical ventilation that I just do not have the time to go over. If you have any particular questions, feel free to leave it in the comments, send me a message. And if a lot of people have the same question, then I can always make another video later as a follow-up. Thank you.